perhaps Dr. Sidlinger, you can lead us by, the CD22-targeted immunotoxin, the mechanism and how it works, the moxetumomab.
Yeah, so that's, as was discussed earlier, this is now approved in the second line or second relapse, essentially. It's an interesting kind of first-in-class type of drug, is fused to a Pseudomonas exotoxin. And so once it is taken into the cell, the toxin inhibits protein synthesis and ultimately triggers apoptosis. So there have been several studies, and recently in ASH, they were presenting data on long-term follow-up with this drug, and patients are having long-term response. We're still waiting for, years out like we have for some of the other drugs, but in patients that are having those earlier relapses, it's certainly something to consider.
Dr. Ravandi, I know you participated in that and published this result, and you participate in this study. You probably obviously have good experience with. What have been your experience with these agents and, the efficacy-wise?
I have to say that my experience in hairy cell has been limited. We have treated a couple of patients. In terms of hairy cell, as you've seen the reports and publications, it is effective in the setting that has been approved. That's second relapse of patients. Dr. Kreinman has shown that in many of these patients, you can get MRD negative responses. And again, the question of MRD negativity comes back. But I think in the relapse setting, it's probably more useful to have MRD negativity because the patient has already shown that it has a tendency to keep coming back. So if you're treating a relapse patient, it might be more prudent to try to achieve an MRD negative response. Obviously, the drug has a couple of side effects that is well publicized. Hemolytic uremic syndrome, that if I remember correctly, tends to happen in about 5 to 10% of patients, and also capillary leak syndrome. That requires a significant monitoring and also asking the patient to drink a lot of fluid during the course of therapy. There are other things that need to be carefully monitored for hemolytic uremic syndrome, including renal function, carefully monitored during the course of therapy. But again, this with good monitoring and with appropriate management, these are generally limited in terms of their degree of incidence and also generally reversible. I do believe that there is a need to use aspirin prophylaxis when you give this drug. And in some patients with low platelets, obviously we would need to be a bit careful. But overall, it is an active drug and it does produce MRD negative responses. And you heard about the long-term follow-up data.
Yeah, I participated in the original trial. An interesting history. The first iteration of the drug did cause quite a bit of hemolytic uremic syndrome, and this is much less. But the patients on that trial, those were truly refractory patients. I mean, these are patients who you had to demonstrate that, after they got cladribine for the fourth time, or they didn't respond at all. So they were without treatment options at that time. And so the drug is quite effective with, as Farhad mentions, quite prolonged responses in that difficult to treat population. So it clearly has a role.
Can someone actually talk a little bit more specifically about the response rate that has been observed in this particular study or this particular agent? I think the one benefit of this agent is the MRD negativity, as all mentioned, the deeper response they were getting for these patients, which may and hopefully will lead to a more durable remissions and the less likely to need another lines of a therapy. But if for those who are more familiar with it, any one of you guys maybe talk about what CR rates do we actually really see in this type of a patients, and then the MRD, the negativity.
In the original trial, the 60 patients, 41% actually achieved a CR, and 27 patients, so 34%, achieved MRD negativity. And of those 24, so of those patients, 30% or 24 patients maintained a remission for over 180 days. So these were truly refractory patients. And so they have done, these patients who have done quite well compared to what they had done with other treatments.
There is some anecdotal experience with a few patients actually being retreated with the drug. So these are patients who first got it as an investigational agent, and now that it's commercially available, have been retreated many, many years later. I have one such patient, for example, that retreated successfully and achieved a nice complete response once again.